Hello, and welcome to our second in the trauma series. This one covers some thoracic things, lung, cardiac, esophagus, diaphragm, aortic injuries, as well as complex extremity injuries, and a brief discussion of the use of ECMO for trauma patients. Usual disclaimer here that this information was collected in the spring-summer of 2024 and isn't meant to represent a totality or the only correct way of knowledge that's out there, but just to add to what you already know. If you're in our Pediatric Surgery Critical Care Fellowship, here's a checklist for things to do this week, which is to look at our guidelines for chest CT and pediatric trauma aimed at limiting radiation, and then the recommended reading. Here's topics that we're going to be covering today: cardiac and blunt aortic injuries, lung injuries, esophageal, diaphragm injuries, and then complex extremity injuries. The majority of cardiac injuries are from blunt trauma. Most of those are contusions related to motor vehicle collisions, often with improperly restrained drivers or passengers. And a smaller number are from pedestrian accidents, falls, and sports injuries. At initial presentation, there's not a very consistent history and physical. For example, only half of neurologically intact, non-intubated patients with blunt cardiac injury had chest pain in one series. However, all patients who have serious complications like heart failure or dysrhythmias present to the ED with either shock or dysrhythmias. Troponin elevations are pretty much useless for the diagnosis of myocardial injury. If there is suspicion, based on pattern of injury plus or minus the presence of shock or dysrhythmia, an echocardiogram transthoracic should be obtained with medical and surgical management according to the injury pattern, with surgery required obviously for the septal or cardiac free wall rupture, but other modalities available for the other problems listed, including observation for minor ECG or cardiac enzyme abnormalities. Special mention amongst the cardiac injuries for commotio cordis, which is an impact to the chest, often from a ball, but it can be another human, in the 40 milliseconds preceding the T wave, which results in ventricular fibrillation, and if there is not defibrillation or resuscitation available within 3 minutes following that, there is a very high mortality. Increased public awareness following some high-profile incidents, which led to a number of Little League and other pediatric athletics facilities carrying AEDs. And here's a video of what this looks like when it happens. Pay attention. And he just falls. So he was confirmed to have commotio cordis. He was within less than 1 minute had medical providers on the field providing him with those therapies, and he actually recovered from his condition and returned to do football. Blunt aortic injuries, these are typically from high-speed deceleration injuries, MVC rollovers, MVC versus tree at highway speeds, for example. The injury is usually in the part of the aorta close to the ligamentum arteriosum, the former PDA. There is some literature out there that a normal chest X-ray is sufficient to exclude blunt aortic injuries. Some personal historical bias against that, and you can see a normal chest X-ray here, and then I'll play this CT scan, and you can see on the top of the aorta here, pretty nice injury that our cardiac surgeons felt needed emergent less than 24-hour before presentation repair. The care of blunt aortic injuries in children is largely borrowed from adult practices and starts in the ED with beta blockade for impulse control. And remember, impulse control means both heart rate and blood pressure control. Common adult goals would be systolic blood pressure less than 110 and a heart rate less than 90. It's usually achieved via an esmolol drip. Depending on the pattern of injury, antiplatelet or anticoagulation, for example, would not be used in a rupture, but in other smaller injuries may be indicated. The Society of Vascular Surgery has some recommendations for modality of repair as well as repeat imaging for these grades 1, 2, 3, and 4 injuries. In the setting of TBI, this requires some individualized care. Lower risk aortic injuries have improved overall outcomes if repair is delayed to beyond 24 hours, but high risk aortic injuries still do need emergent repair. There's an unknown natural history of these, and progression has been seen fairly far out, more than 2 years following the injury. And so it's not really clear how long to follow these and at what point to consider intervention. For example, even if the repeat CT scan at 72 hours showed stable pathology. After open or endovascular repair, if you're in the ICU, spinal drainage might be present depending on the surgeon. It's not recommended routinely. And then follow-up for these repairs is important as well, to not forget about that risk of late progression. Moving on to our next topic, lung and pleural space injuries. In contrast to the rigidity of the rib cage in adults, the pliability of the chest wall in children allows for a more direct transfer of energy directly to the lungs without significant shielding, with significantly higher rates of pulmonary contusion. We're going to talk about that, as well as pneumo and hemothoraces, tracheal bronchial disruptions, ARDS, and the role for ECMO in the next couple slides. Starting with our most common injury, which is contusions. And this is hemorrhage, edema, consolidation in infected parts of the lung. It can lead to VQ mismatches, hypoxia, hypoventilation. Pneumatoceles can form as a result of alveolar rupture into the parenchyma. These injuries generally heal pretty well within a few days, although they do carry significant pneumonia risk, and these x-rays are taken from the paper below, showing pulmonary contusion with the initial picture here in A, the chest tube placement for a small pneumothorax in the next one, with trend towards healing at day 8 and a normal x-ray not shown at 1 month. Pneumothoraces and hemothoraces. So there's been a trend, especially for pneumothorax, over the last decade or so, towards doing less intervention for them. And so initially, occult pneumothorax, which is those seen on CT scan but not on X-ray, especially if they're less than 16 millimeters, could be safely observed even in those who were intubated on positive pressure ventilation. And then more recently, non-occult pneumothoraces, so those that are seen on X-ray, if they're not terribly symptomatic, secondary to blunt chest trauma, can also be safely observed, as well as small hemothoraces. In addition to doing fewer tubes, the size of the chest tube has decreased, and when I was first training, we were trying to place in the mid-30s due to some notion that they drained blood and clots better, but now it's recognized that clots don't come out no matter what size the chest tube is, and that small chest tubes as small as 14 or even below can drain blood and air just as well as larger ones. Role for surgery for these diagnoses, immediate blood loss or ongoing blood loss, suggesting that there is significant vascular injury requiring operative intervention. Small air leaks usually resolve with pleural drainage. However, large air leaks should prompt concern for tracheobronchial tree disruption, either needing surgery or more advanced care, which we'll talk about in a subsequent slide. In contrast to adults, where infectious complications like empyema of retained pneumothorax are well described and early events with evacuation is recommended, it's not clear if this carries over to children, with one study showing that it does not. And so the role of early VATS to evacuate pneumothorax with the notion of preventing empyema is less defined in children. Tracheal bronchial disruption, as we mentioned in the last slide, is from a large ongoing air leak. These are rare. Often they're quickly lethal, and so you won't even see the presentation. If able, a flexible bronchoscopy is recommended to locate and assess the extent of injury, with subsequent management being dictated by the severity. If it's a contained injury with pneumomediastinum, but not free rupture into the pleural spaces, these can often heal spontaneously, with tube thoracostomy and temporary intubation past the tear if possible for more moderate injuries, and then severe injuries again, possibly needing surgical repair plus or minus ECMO. ARDS. So here's some data from a single center level 1 pediatric trauma center just under a decade, where they had almost 2,500 pediatric trauma admissions. Of those, 100, a little over 100, met criteria for PRD ARDS, with a pretty high mortality, about a third overall, either as a result of neurological injury or multisystem organ failure. Those with ARDS, only 23% were discharged with normal function compared to 70% of the survivors that did not have PRDS. Noting that that's not necessarily from the ARDS itself, but maybe a marker of more severe multisystem trauma. That being said, in light of that increased mortality, what is the role for ECMO? So in adults, the use of VA ECMO in trauma patients has historically been discouraged due to high mortality, but VV thought to be beneficial in certain conditions. But things are starting to turn around a little bit, and now both VA and VV ECMO are being used in adult and pediatric trauma with better outcomes. Here's 3 papers from 2015 to 2020. The largest of which had 573 patients, mean age nearly 5, about half VA, the other half VV ECMO. And these are mostly drowning, burning, and thoracic trauma. You can see that VV ECMO had a significantly greater survival, 74% over VA. Interestingly, no increased rate of hemorrhagic complications, but those were in line with also historical rates, as were overall complications. And the authors concluded that trauma should not be a contraindication to ECMO in kids. What are those indications? Severe thoracic trauma with PARDS, severe air leak, trauma pneumonectomy, possible cardiovascular collapse, and some of those included in those studies were even ECPR, although that is certainly more controversial. Neither trauma nor head injuries are absolute contraindications to ECLS or ECMO. And again, this is discussed in the ECMO series, but pre-ECMO coagulopathy does not increase the rate of hemorrhages, and it is possible to place trauma patients or other patients on ECMO with no anticoagulation initially, followed by either heparin with a low target or no anticoagulation for a short time. For both adults and children, esophageal injuries are more likely following penetrating than blunt trauma. When it is in blunt trauma, it's most likely a rupture of the distal third of the esophagus into the left chest, similar to the Boer-Haave syndrome. Both contrast esophagograms and esophagoscopy have been used for diagnosis. In contrast to adults for whom operative repair is recommended for injuries presenting within 24 hours, there is high rates of success with non-operative interventions in children, and should be considered depending on the grade of injury and status of the patient. Diaphragm injuries, again, more common for penetrating than blunt trauma, although it is still possible, especially with impacts to the stomach, those increasing intra-abdominal pressure to send those organs through the diaphragm north and cause some injury. These do require urgent operative repair, and there's often associated injuries to the liver, spleen, bowel, etc. Moving on, we're going to talk about what you need to know about complex extremity injuries, including traumatic rhabdomyolysis, compartment syndrome, open fractures, mangled extremities. So, traumatic rhabdomyolysis, aka the crush syndrome, studies from pediatric victims of earthquakes give us the most detail about management. Fractures and soft tissue injuries are the most common injury in those studies, with about 30% incidence of crush. And they gave us some predictions of the need for renal replacement therapy beyond the usual indications. And so they said CK level above 40,000, body area crushed greater than 30, and increased phosphorus. These patients also do have a higher rate of venous thrombosis, and so should be considered for prophylaxis. In my own training, we used to use renal replacement therapy with a high flux filter in adults, which in Baltimore was 15 years and up, in patients with high CK to remove myoglobin to try to prevent AKI, which is effective at clearing the myoglobin. It's less effective whether it changes, less clear whether it changes outcomes. No strong evidence to support doing that, and so current recommendations seem to suggest usual indications for renal replacement therapy. Here are the guidelines from EAST for management of rhabdomyolysis. The first principle is identification and release of any compartment syndromes in the upper or lower extremities or gluteal compartments. They recommend against the use of bicarbonate to alkalize the urine, which does not improve outcomes or reduce the need for RRT. There's similar recommendation against the use of mannitol. They do recommend aggressive IV fluid resuscitation for a CK above 5 to 10,000. with not well-defined volume targets. They did support the middle range of published reports, which was 2 to 3 cc's per kilo per hour, and continuing that until there was clearance, defined as CK below 5,000. Muscle compartment syndromes in children. Several distinctions from its adult counterparts. For one, the recognition is more difficult. Children have reduced capacity for communication due to their age or their comorbid trauma conditions, including TBI, for example. There's a longer time from injury to peak pressure compared to adults. The 5 Ps are unreliable in children, although pain is the most common symptom. There's been an alternative proposed, which is the 3 A's: agitation, anxiety, and increasing analgesia requirements. Because of these diagnostic difficulties with physical exam and history, there's a higher rate of pressure measurements prior to fasciotomy. The problem with that is that there's not a universal pressure threshold. Some of the more common ones used are an absolute intercompartment pressure of 30 milligrams of mercury, or a pressure within 30 millimeters of the diastolic pressure. On the bright side, although the time to diagnosis may be delayed in children compared to adults, there is more forgiveness of the time to fasciotomy, and the traditional teaching for adults that 8 hours of ischemia results in permanent myonecrosis doesn't seem to carry through to children, in whom a meta-analysis shows that even those with time to fasciotomy greater than 24 hours have high rates of achieving full functional recovery, which led to recommendations again for delayed presentations of these in adults, where you might leave the skin intact to prevent infectious complications. Don't apply to children, in whom you should go ahead and do those fasciotomies, understanding that there is higher rates of recovery in children, as well as lower rates of post-fasciotomy infections. Some things to know about complex extremity injuries: open fractures, contaminated penetrating injuries, gunshot wounds through clothes. The bullet tends to track cloth fibers or other materials through the wound, and these should undergo operative washout and debridement. Antibiotics for open fractures. There is going to be some institutional variance. You should look at your own guidelines for this due to the paucity of high-quality evidence. In general, all pediatric patients with open fractures should receive cefazolin as soon as possible from injury, ideally within 3 hours. Duration for which those antibiotics are given is variable. There are common practices of adding other antibiotics for specific types of injuries, although the strict evidence for doing so is not as present. Complex extremity injuries can be tough to visualize, tough to manage. They are fortunately infrequent, often from penetrating injuries, for example, punching through glass doors. Here on the right you see what's called a spaghetti wrist, which is a severing of most of the tendons and nerves, and then a following reconstruction. For vascular reconstruction, autologous grafts, saphenous vein are preferred. Keys to know here: you can do shunts if you're not equipped to do those vascular repairs, and tendon and nerve retraction tends to occur over time, so those need to be repaired in a timely fashion. But the big ECMO trauma study for recommended reading. Let's move on to the quiz. A 16-year-old driver involved in an MVC with chest x-ray suggesting sternal fracture. He has normal vital signs, has normal sinus rhythm on the monitor. What else do you want to do to exclude a blunt cardiac injury in the setting of that chest x-ray? Serum troponins at 12 EKG, some from echocardiogram. None of the above are really needed, although no one would fault you if you got an EKG, really. A 6-year-old was playing in her parents' pickup truck, and it reverses into a pond on their property. The mother is able to extricate the child. CPR is startled with pre-arrival ROSC. The child arrives intubated, is started on the usual post-arrest protocols, and over the next 24 hours has increasing ventilator requirements, opacities, and the team calls you to consider ECMO. While drowning patients aren't classically included in the ACMS trauma definitions, they are sometimes grouped in with the trauma ECMOs. So use of ECMO in this patient may be a bridge. It's contraindicated due to poor survival neurological outcomes. You should only do VV. And actually, in that largest study of about 550 to 600 pediatric patients, drownings were 38% of them, a large proportion with around 50% survival. 4-year-old is intubated by EMS following MVC and is currently in the PICU with severe TBI, multiple extremity fractures. Urine output's declining. It's just with thermodynamyelitis. Compared to adults, pediatric compartment syndromes are harder to recognize. They have better outcomes. They have less clearly delineated intracompartment pressure thresholds with Stryker needle or other needle monitoring, or all of the above. All right, a little bit of a shorter talk today. Enjoy the rest of your day, week, month, year. See you next time.